Quellicin, or nectine, more commonly known as succinylcholine, typically comes in a powder form in a 200 mg flip-top vial. There is, however, a formulation of 1,000 mg. The 200 mg powder is usually reconstituted in 10 ml of 0.9% sodium chloride, yielding a typical concentration of 20 mg per milliliter. The powder form of succinylcholine can be stored at room temperature. If succinylcholine multidose vial has been reconstituted, it should be stored in the refrigerator. The reconstituted multidose vials are stable for up to 14 days at room temperature without significant loss of potency. Acetylcholine is a neurotransmitter released from the nerve terminal at the neuromuscular junction. Two acetylcholine molecules bind to the alpha subunits, one each of the nicotinic M acetylcholine receptors on the motor end plate of a muscle cell. This causes a conformational change of the receptor, causing it to open and allow cations to exchange freely across the membrane, specifically sodium in and potassium out. The amount of sodium that enters the cell is greater than the amount of potassium that leaves, causing a depolarization and ultimately the generation and propagation of an action potential along the T-tubules in the muscle fiber. As a result, calcium is released inside the cell. It is the increased concentration of calcium inside the cell that allows muscle excitation coupling to occur. Acetylcholine only stays bound to the receptor subunit for approximately 1 millisecond before it quickly dissociates and is bound and metabolized by acetylcholinesterases present in the neuromuscular junction. This rapid binding kinetic profile allows prompt dissociation of acetylcholine from the receptor subunit and allows the receptor to reset and await the next round of acetylcholine ligands to repeat the process after the cell membrane repolarizes. Succinylcholine, a depolarizing skeletal muscle relaxant, acts much in the same way as acetylcholine. In fact, succinylcholine is actually two acetylcholine molecules bound by their acetyl groups in an ester bond. Two succinylcholine molecules are also required to bind to the receptor in order to cause the conformational change. Succinylcholine competes with acetylcholine for the receptor site. Once bound, succinylcholine remains there anywhere from 3 to 5 minutes. This persistent depolarization does not allow the receptor to reset and thus does not allow the cell membrane to repolarize. Even though calcium is sequestered back into the sarcoplasmic reticulum, no further muscle contractions can take place as a result of the inability of the acetylcholine to reset. This is why we observe muscle flaccidity rather than tetany following fasciculation. The most common route of administration of succinylcholine is intravenous injection. The typical adult intubating dose ranges anywhere from 0.3 to 1.1 mg per kilogram. On average, twice the ED95 is 0.6 mg per kilogram. Other effective routes of administration are intramuscular injection at 3 to 4 mg per kilogram and intraosseous injection at 1 to 2 mg per kilogram. Oral administration of succinylcholine is not recommended as it is a charged molecule and cannot be absorbed into the plasma from the GI tract. Once the patient has been induced and unconsciousness verified, succinylcholine is administered to facilitate tracheal intubation. The vocal cords are controlled by skeletal muscle, and succinylcholine will only relax skeletal muscle. After the specified amount of time has passed and skeletal muscle relaxation verified, endotracheal intubation can be performed. Intravenous and intraosseous injection have similar onset, ranging from 30 to 60 seconds. Intramuscular injection, however, has an onset of 2 to 3 minutes. Again, intravenous and intraosseous injection are similar in that their peak action occurs approximately 1 to 2 minutes after administration. Succinylcholine is rapidly metabolized by butyrylcholinesterases, also known as pseudocolinesterase or plasmacolinesterase. Succinylcholine begins to be metabolized as soon as it is injected. Therefore, only a few succinylcholine molecules actually reach the neuromuscular junction. Because there is few, if any, plasma cholinesterases in the neuromuscular junction, simple diffusion from the neuromuscular junction to the plasma is responsible for terminating the clinical effect of succinylcholine. Once in the plasma, pseudocholinesterase metabolizes the drug by cleaving the ester bond. This diffusion occurs 3 to 5 minutes after it is bound to the receptor. The duration to 25% recovery is 6 to 8 minutes following a dose of 3 times the ED95. The body is completely rid of succinylcholine in approximately 20 minutes. Succinylcholine is not lipid-soluble and therefore does not distribute into tissues. Its distribution is limited to the extracellular space. This helps explain its rapid onset and ultra-short duration. The distribution half-life, or T-half-alpha, is 17 seconds. The elimination half-life, or T-half-beta, is quick, approximately 5 minutes. Again, succinylcholine is rapidly metabolized by butyrylcholinesterases into succinylmonocholine and choline. 10% of the dose injected is excreted unchanged in the urine, as well as some of the succinylmonocholine. Succinylmonocholine has 1/20th the effect of succinylcholine and may have non-depolarizing neuromuscular blockade properties. It is hydrolyzed slowly and accumulation may occur, prolonging apnea in your patient. Succinylcholine is used to induce skeletal muscle paralysis prior to endotracheal intubation. It can also be used at a 0.1 mg per kilogram dose to break laryngospasm. Succinylcholine remains the only depolarizing neuromuscular blocking agent used clinically at present. There are several contraindications to the use of succinylcholine. The most significant absolute contraindication to succinylcholine is an allergy to succinylcholine or a disposition for malignant hyperthermia. A relative contraindication is a reduced amount of circulating pseudocholinesterase. This can be due to pregnancy, liver disease, renal failure, and antineoplastics. However, if the patient has a genetic autosomal recessive trait that causes variations in the enzyme, succinylcholine should not be used. A dibutane or fluoride number can be obtained to test for properly functioning pseudocholinesterases. Dibutane is an amino-amide local anesthetic. When administered intravenously, it is capable of inhibiting pseudocholinesterase. The dibutane number is a measure of the qualitative activity of pseudocholinesterase and is the percentage of inhibition of the enzyme by dibutane. Other absolute contraindications are muscular dystrophies, neuromuscular diseases, demyelinating lesions, patients at least 24 hours post third-degree burns, trauma or multiple crush injuries, and prolonged immobilization greater than 3 days. All of these situations cause an upregulation of nicotinic M acetylcholine receptors. The likelihood of the patient experiencing life-threatening hyperkalemia is very great. Finally, succinylcholine is not for routine use in pediatrics.